Okay, so today we're just going to be talking about Presbyond. So Ravi did briefly touch on the Presbyond at last CPD event. So we've been doing a lot more in the clinic lately. So I'm just going to kind of go over, what to expect with Presbyond and our patient kind of outcomes so far. So just talking about the initial kind of clinical approaches to presbyopia that we know most patients kind of go for. We've got things like monovision, the EDOF IOLs, we've got multifocal IOLs, multifocal glasses. So talking about the drawbacks of the monovision, some patients can get a decreased contrast sensitivity and they can get a bit of decreased stereo as well. For CLEs, it's a great option, but looking at younger patients, early 40s, they will lose that residual accommodation. And if they haven't had a PVD, they're still yet quite young, they are a bit more of a risk for postoperative cystoid macular edema. So what exactly is Presbyond? Presbyond is a LASIK-based corneal procedure that aims to give it an alternative to traditional IOLs or traditional monovision. So the way that Presbyond works is it combines the aspheric microanisometropia with an extended depth of focus, and this is achieved through controlled spherical aberration. So this procedure is a binocular vision procedure. So similar to monovision, we have a dominant eye that is corrected for plano or for distance, and a non-dominant eye that's kind of a near target, depending on the patient age, can range from 0.75 to -150. The difference with the Presbyond and normal monovision, as you can see here in this diagram, traditional monovision, you get this kind of intermediate blur zone. You've got great distance vision, great near vision, but this intermediate can be quite blurred. Whereas Presbyond, you can see here, we have this blended transition zone in the intermediate, which gives them more of an increased depth of field in comparison to traditional monovision. So how this works, so we know that when we're refracting, about 10% of blur in the average eye is kind of caused by different aberrations, spherical aberrations, other higher order aberrations like coma, astigmatism, all those kinds of things. A lot of IOL companies can manipulate these other higher order aberrations, specifically spherical aberrations, to give a bit more of a longitudinal focus. And the way that that's kind of happening is that instead of, every ray being refracted into this single focal point, like you can see here, differing rays that are a bit more paraxial and a bit more peripheral refract either, before that general focal point or after, which gives this kind of blurred, elongated point focus, which gives us, this EDOF kind of look. So it is still sitting in that circle of least confusion so that the brain is also able to adapt to that bit of blur to give you a clear image. So just talking a little bit about spherical aberrations, in an ideal optical system, there would be, a single point focus, there'd be no aberrations, and you'd have this beautiful point focus refraction. In positive spherical aberrations, we can see here that these peripheral rays are refracted a little bit more than these central rays, which gives you these kind of two spread point focus here. And then the opposite is true for negative spherical aberrations. So these central rays refract a bit sooner than the peripheral, which gives us this two spread point focus, which increases that longitudinal focus and gives us more of an enhanced depth of field. So talking about patient selection, look, the ideal refractive limits for this one is a spherical equivalent of about -8 diopters up to about a +3, and they can handle about 250 diopters of SIL. So for more experienced surgeons as well, the machine does have the capability to go up to -14 diopters and +8, and can go to a total of 6 diopters of SIL as well. So talking about contraindications, pretty similar to other LASIK contraindications. So we're looking at thinner corneas, any previous kind of corneal dystrophies, keratoconus, PMD, any of that kind of thing. Any active inflammatory or infectious diseases. If they've got some amblyopia, moderate to severe, generally that will give them, poor results because it is a binocular vision-based procedure. Again, unstable refractions, if you've got a refraction that's kind of changing or progressing quite rapidly, generally not a good candidate as well. And then lastly, any kind of signs of cataracts or any intolerance to blur, which I'll talk about in a moment. So these are the kind of imaging and, investigations that we're doing at the initial appointment, just to kind of really double check that the patient's a good candidate and then their ocular health is really good. Another benefit to Presbyond is you can compare, functional age versus, patient's biological age. So for example, a patient that's 40 and has a little bit of residual accommodation may be more accommodative kind of towards that 50 age limit. And generally we just check that with a push-up test. So talking about the tolerance test now, so this is basically a cross blur check that we can kind of determine how much anisometropia the patient can handle between the two eyes without kind of degrading that image quality. So generally what we do is we start with our endpoint refraction, which is generally subjective refraction. Throughout the subjective refraction, you push as much plus and as much minus as possible to kind of just ensure that you're not having any, residual astigmatism or residual hyperopia or any of that kind of thing. And then we start with the highest amount of anisometropia, so we put an extra minus 150 into the phoropter. Easiest way is just to pop your ret lens in, and this will be put in the non-dominant eye. If the patient's a bit intolerant to the full minus 150, you can be titrated down. You can go down to 125, then see if they can tolerate it, -1, and then to -0.05. Like I said, generally it's put in the non-dominant eye. However, some patients do have a bit of cross-dominance, so they might prefer the bit of extra minus in the dominant eye. So always double checking dominance with a few different testing methods and seeing which they kind of prefer as well. So talking about post-op expectations, so Presbyond does have a bit of a longer healing period than traditional LASIK surgery. The reason being is that the brain is adapting to that microanisometropia as well as the spherical aberration. So it does take a while for that refraction to settle. Generally, in the first 1 to 3 weeks, refraction is quite unstable. Myopes typically tend to have great distance vision, but they notice initially that their near vision is not great. The opposite tends to be true with hyperopes. Their near vision is generally a little bit more overcorrected, and their near will be great, but their distance will look blurry. As that refraction settles, kind of the 2 to 3 month mark, that will all kind of shift out and give them that really great intermediate blend zone. And then generally everything's kind of, neuroadapted to the 6 to 12 month mark, and most patients are kind of fully adapted and stable within that 6 to 12 month mark. So talking about just managing some post-op dry eye, this is particularly for LASIK. The main kind of proposed mechanism of how LASIK contributes to dry eye is the iatrogenic corneal nerve damage. So we know that with a flap, it's generally cut about 100 microns, which does kind of disrupt the subbasal nerve plexus and some of those anterior kind of stromal nerves as well. That can, aggravate some dry eye, particularly in that early post-op period. The other kind of proposed theory is that the post-op inflammatory changes can contribute to a bit of inflammation and cytokine-induced mediation reduction in the tear film quality and quantity. So the most effective management strategies, is initially in pre-op or when the patient's seeing their optometrist for that initial referral, just identifying and aggressively treating any pre-existing dry eye. Generally for post-op causes, we pretty aggressively treat any kind of dry eye, even if it's very minimal, just to ensure that they're kind of minimizing those dry eye symptoms. So in most cases that are very mild, we just give, intensive lubricants on preserved artificial tears hourly. In more moderate cases, we might consider things like punctal occlusion, temporary kind of silicone plugs. In more kind of severe cases or intolerance to any of the punctal plug, we can look at more punctal cautery or more thermal, occlusion. Obviously, treating our coexisting MGDs, using our heat compressors, our lid scrubs, making sure that they're doing that digital massage as well. We also can look at things like short course oral tetracyclines, a short course of kind of pulse steroids and omega-3s. Then we've got for more the severe category, typically it doesn't get to this stage, especially if it's really, identified and aggressively treated in that very early post-op period. But we do have things like cyclosporin, autologous serum, and really, really bad cases, we do have things like therapeutic scleral lenses as well, or the PROS system. So just to kind of briefly touching on SMILE, you can see here that obviously the LASIK flap is quite large. We've got about 20 millimeters of incision there in comparison to the SMILE, that's about a 4 millimeter incision. SMILE tends to have a bit less post-op dry eye symptoms. If you are worried about post-op dry eye in a particular patient, it is a little bit more minimally invasive than LASIK. It has a little bit more of a minimal risk of things like post-op ectasia. Previously, SMILE was only really available to myopes. It is approved now for hyperopic patients, so it goes up to about a +7 in terms of the refractive limits and about 4 diopters of SIL. Whereas myopes, you've got a pretty big refractive limit. You can go up to -10 with a whole 3 diopters of SIL. So just talking about some post-op expectations, particularly for, the more regional optometrists who are seeing our post-op patients, kind of what to expect in terms of visual recovery. So LASIK tends to have quite a good, fast visual recovery. Generally, their vision's quite good in the first 1 to 3 days. I'd say most patients are seeing, 675, 66, day 1, day 2, which is great. Advantages of LASIK, we've got a pretty low risk of corneal haze in comparison to other things like PRK and trans-PRK. It's pretty minimally, painful, and you get quite immediate results. Disadvantages of LASIK, we do have risk of, flap complications. So for patients, seeing their own optometrists, we're looking for things like striae, we're looking for any kind of, movement or dislodging of the flap. Obviously, it is a big of a risk for dry eye, and it can impact some of the corneal dynamics. So some people get some neurotrophic issues afterwards. And obviously, there's that risk of that post-op corneal ectasia. So generally, time off work, we're only really recommending 1 to 3 days with LASIK. But in terms of the post-op period, they are told to kind of, keep things nice and easy, clear environments for at least 2 weeks. They'll be on, a antibiotic and a steroid drop for about 2 to 3 weeks afterwards. In comparison to PRK and trans-PRK, that has a quite slow visual recovery. So generally their vision will be quite blurry for the first week. They'll have a bandage contact lens in that first week as well. That'll be removed after a week. Then they will be put on a little bit of a stronger steroid. They typically switch to Maxidex that first week once the contact lens comes out. Generally, there'll be quite a bit of disruption to the epithelium at this stage too. It's quite irregular. I have a slightly raised area in the center, which can be quite blurry for the vision. Generally, the vision starts to settle after about 2 to 3 weeks with the trans-PRK and the PRK. It does take quite a bit longer than LASIK and SMILE, but good advantage of the PRK and the trans-PRK is it's a lot more suitable for thinner corneas, a little bit less risk because obviously we're not cutting that flap or the lenticule like we are with SMILE. Disadvantages, like I said before, pretty delayed visual recovery. You've got a bit more of a risk of corneal haze. It's a lot more uncomfortable for the patients as well. And then your post-op schedule, you're on, some steroid drops for about 6 weeks in total. Generally, depending on what the patient does for work, we recommend at least 1 to 2 weeks off because it is, like I said, quite a slow visual recovery. And then looking at SMILE, again, it's quite a fast visual recovery. Typically, hyperopes tend to have a little bit of a more difficult time in that very early post-op period, but everything generally tends to settle down in that first week. Advantages, we've got, fast recovery, it's a lower incidence of dry eye, and we don't have to worry about flap complications with SMILE. One big disadvantage of SMILE is at this stage, there's no kind of touch-up procedure for SMILE. So if there is any residual kind of refractive error, they generally tend to move to a PRK just to reduce that, residual refractive error. And generally recommend only kind of 1 to 3 days off work, but again, that 2-week post-op period, just taking it easy. So just looking at our multiple choice questions, the primary purpose of Presbyond treatment is to A, treat cataracts, B, improve refractive error, and C, improve near vision. The answer is both B and C here. Question 2, Presbyond is most effective for patients younger than 40, between 40 and 60, or C, over 60, and the answer is B. Looking at the third question, what is one advantage over SMILE over LASIK? A, it corrects both near and distance vision. B, it does not require creation of a flap. And C, it can only be used for myopia. The answer is A and B. Thank you so much.